Hello, friends and fellow surgeons. Welcome back. I'll be demonstrating a case of laparoscopic truncal vagotomy with a Braun loop gastrojejunostomy for a chronic duodenal ulcer patient in gastric artery obstruction. So this clip shows upper GI endoscopy of the same patient, where you can see multiple antral erosions with dense scarring at the pyroduodenal junction. So these are the steps of the surgery, and yeah, like we do, the first step is the patient position. So the patient is placed supine and in leg split position. Pneumoperitoneum is created using a classic Hassen's technique. And then comes the port positions, where I've used 110 mm, 112 mm trocar, and 3 5 mm trocars, wherein that the left hypochondriac 5 mm trocar is an additional trocar. So before starting any upper GI surgery, the first step is to empty the stomach by suctioning the contents and removing the Riles tube. And then, so I'm opening up the pars flaccida. Once you open up, you can see the caudate lobe of the liver. You have to be more careful when you find any accessory left hepatic artery, where you have to safeguard the artery. So it is not necessary that you have to preserve the hepatic branch of the vagus nerve, which I've just taken it down. So I'm releasing the pars flaccida, marching towards the right crus, and then I'm dissecting the phrenoesophageal ligament to get access into the hiatus. So once over here, you have to be more careful because your anterior vagus nerve will be more closer to the proximity. So once that is done, so you're gonna enter your just run your harmonic, the active limb of the harmonic, over the right crus. So these are the principles how we do a hiatus hernia surgery. I'm entering into the anatomical planes here, which is fairly easier and lax in case of a hiatus hernia rather than in this surgery where the hiatus is snug. So I'm doing a bit of a sharp and blunt dissection. You can see I'm releasing up some more of the phrenoesophageal connections. So the goal is to gently dissect around the esophagus, preserving the hemostasis and staying close to its wall, so that we can identify both the anterior and posterior vagal trunks. And you see, that is the additional trocar I was talking about, the 5 mm left hypochondriac region. This fairly because to give traction when you dissect around the retroesophageal window, we have to make that constant pull on the esophagus. So, and then comes your third step is to identify the anterior vagus nerve. So you see, anterior vagus nerve will lie in close proximity to the esophageal wall and slightly towards the left. So you have to be more careful and meticulous when you do a phrenoesophageal dissection. And once you identify the vagus nerve, you basically have to skeletonize it from the surrounding structures. And you can either clip it or seal it and divide it. And always, it's a protocol to take a chunk of the nerve for the biopsy. So you see, just identify the anterior vagus and I'm skeletonizing it. And now I'm using a harmonic scalpel for a chunk of biopsy. So that is the anterior vagus identification and division. And now comes a fourth step, which is a posterior vagus identification. Your posterior vagus nerve usually lies away from your esophagus and to the right side. So the posterior vagus is usually seen hidden within the esophageal fat. And see, now that I've identified the posterior vagus, again I'm using a harmonic scalpel to dissect it and take a bit for the biopsy. So this completes our identification of the posterior vagus. Now we're gonna move our attention towards the gastrolysis. So over here I'm emptying the stomach again, and I'm gonna prepare a suitable site for the gastrojejunostomy, which is basically at the antropyloric junction, just at the pylorus. I'm doing a gastrolysis over here at the greater curvature. So you have to be very close to the stomach, where you're not going to take off the gastrocriploic arcade. You're going to take off the marginal branches there. I'm gradually preparing the bed for my gastrojejunostomy. Uh, so when you do these advanced procedures, for someone who is starting, it's better to have a senior person around before you proceed with those advanced laparoscopic procedures. And the dimension for a gastrojejunostomy is usually 7 centimeters. So you see, I'm doing a gastrolysis for 7 centimeters anastomosis, and I usually do a stapled anastomosis for a gastrojejunostomy because of one, the stomach wall will be edematous. Number two, the patient will have low albumin because of chronic gastric outlet obstruction. So it's better to have a good stapled anastomosis rather than having a lap sutured or lap sewn anastomosis. Again, it's a surgeon's preference of either using a stapler or a simple laparoscopic suturing. So then comes the next step, which is selection of the jejunal loop, where I've retracted the transverse colon cranially. Now I'm looking for the ligament of Treves, where we can see the inferior mesenteric vein. Once you see the inferior mesenteric vein, that finalizes that is we are at the duodenojejunal flexure. Now I'm going to measure 5, 10, 15, 20, 25, 30, 35, 40, and 45. So this will be the proximal jejunal loop for our gastrojejunostomy. And usually the loop should comfortably reach the stomach without tension or twisting. So this loop is brought up in an anticolic fashion towards the site of gastrojejunostomy and gastrojejunal anastomosis. So here I'm using 20 ml silk as stay sutures to align both the loops for side to side gastrojejunal anastomosis. And now I have shifted my camera port to the 12 mm trocar, where I'm using umbilicus 10 mm and right hypochondriac 5 mm port as my working ports. This I shifted because it gives me better ergonomics while doing stay suturing, and it makes an added advantage by looking your anastomosis right under your vision with two working trocars triangulating to your anastomosis. So now that your stay sutures are almost done, the next step is to do a gastrostomy and a jejunostomy for your stapler insertion. For the insertion of the staple, I'm going to shift my camera to the 10 mm trocar. So see, now I'm doing a gastrostomy. While doing a gastrostomy, you have to be more careful because the stomach will be thick walled because of chronic GVO, and you have to make sure that you enter the mucosa. So you shouldn't enter in a submucosal plane. You see, now that you're making sure that I've entered the mucosa, and then I'm doing a enterotomy over the jejunum. So, and again, you have to enter the jejunal mucosa and make sure that you're in the lumen of the jejunum. So I'm using a linear endo-GIA blue color staple, and I'm introducing initially into the gastric lumen, then entering into the jejunal lumen to start firing. So the principles of staple firing is one, first you have to make sure you've aligned both the loops. Second step, you have to give a pre-compression for 1 minute in case of endo-GIA and 15 seconds in case of an open stapler. Once you're done with your 1 minute, you have to check underneath, making sure you've not taken up any part of the momentum or there is no um additional structures in between the suture line. Once that is done, then comes your firing. So you fire for again, then hold on for 1 minute, then you're gonna slowly release it. So once your stapling is done, you should always inspect the staple line for any bleeding. as we can see, there is no bleeding per se, and we can differentiate between the gastric and the jejunal mucosal side. Now we're gonna pull the Riles tube and place it past our gastrointestinal anastomosis. The reason we do it is it doesn't put much pressure on the anastomosis, number one. Number two, it keeps the gastrointestinal anastomosis in line with the dependent portion. And then comes the enterotomy closure. Over here, I'm using a 20 PDS. The reason I use 20 is the needle size is pretty much good to handle. And the principle I follow in closing any enterotomy is uh, have a posterior stay suture. So to have a good laparoscopic suturing skills, it's better to invest in a endo trainer. It's better to have one endo trainer at home, and you practice it probably depending on your skill every day almost. It's better to spend time or invest time in the endo trainer to have a really good laparoscopic skills, laparoscopic suturing skills. So now that we have taken the posterior stay sutures, I'll tell you why posterior stay suture is more important in case of any intraotomy closure, in case of laparoscopic suturing. And so once that is done, I'm going to start my intraotomy closure using the same 20 PDS, starting from anterior. So I'm going to take another stay bite further away from the intraotomy site, where I'm going to use it as an anchor bite, and I'll be doing a continuous closure here. The the rule of any bowel anastomosis remains the same as it says more serosa and less mucosa. I'm gonna follow the same principles, but there are certain the methods of doing bowel anastomosis like extra mucosal bites, where to say that serosal approximation is better than using a more serosa and less mucosa approach. So now that I'm almost getting done with my anchoring bite, I'll be starting my continuous suturing soon. You see, your assistant, well trained assistant, plays a major role in making your life easy by following the thread. So I'm gonna take more serosa and less mucosal bite in the stomach, and followed by the same on the jejunal side. And I'm gonna run through my sutures to finish up my enterotomy site. You see, now the next action is to pull the thread and give it to your assistant to make it as a traction. So this is how we do in case of a open case where we follow the assistant will follow the thread. The same principle is being used here, where like we're gonna take the bite and the assistant's gonna follow the thread. Similar steps are being followed throughout our anastomosis. You have to make sure you're making a good airtight anastomosis and you're taking a good healthy bites. Uh, One more thing is you have to ride your needle. You shouldn't poke it. So once you've done, you have to pull the thread and then make sure that jejunum sits comfortably, or uh, the approximation becomes better with the stomach side. Again, you have to be more careful by not taking the bite on the Riles tube, which you have kept it across the gastrojejunostomy side. You see, it's the same steps that have been repeatedly doing on. First, taking the bite on the stomach wall, then taking the bite on the jejunum, then approximating both the gastrojejunal side. And the next step, or the next following habit should be the assistant should come hold your free thread. So these are simple steps which you should make sure you follow it, because it is always step one after step two after step three. There is no step three before step two. So you have to make sure that you follow these steps. It is the same as we do in case of our open. So you see, now this is the reason why our the posterior anchoring bite will comes to help. Once you start suturing your enterotomy, your posterior wall, or the posterior part of the anastomosis will get buried underneath. So if you've taken a good posterior anchoring bite, you can expose the posterior anastomotic site, and you can seal it properly, because most of the leaks are from the edges of the anastomosis. So these are the principles how you close your stapled anastomosis introtomy site. Number one, take a good posterior anchoring bite. Number two, take a good anterior anchoring bite. Then it's your preference to either close it in a continuous fashion or in a interrupted fashion. Over here, I'm always using a continuous fashion. And when you're using a continuous fashion, the steps to be followed are: take a good bite, more serosa, less mucosal bite on gastric side. Then the same followed on less mucosa, more serosa on the jejunal side. Then follow the thread to place your sutures in right line with the suture line. Then then the last thing is to hand over the free thread to the assistant to follow it. So these are the simple steps to do an enterotomy closure in case of a stable anastomosis. We're almost coming to the edge of the suture line by exposing the posterior wall. I would like to again thank my mentor, Dr. Gautam MS, sir, for teaching me bowel anastomosis. For those young surgeons out there and for those who have been practicing, please do find a mentor, because having a mentor makes a huge impact in our lives, for us who like guide us throughout the part of the time. And you can like it feels special, or it feels motivated or supporting when you have someone online always, when your cases are like a bit difficult or you're going a bit sideways. It's always a blessing to have a mentor in your life. I mean, I'm so thankful that I've found Gautam sir. So yeah, I mean, we're almost I'm almost completing my gastrojejunostomy. So this is the final few bites at the edge of the gastrojejunostomy. So when you don't take that posterior anchoring bite, these are the places where where you tend to miss those gaps, and you end up in a catastrophic postoperative complications, which is totally not acceptable. So please follow the principles which have been formulated by our seniors, and learn safe surgical skills from your mentors or from your seniors or from your teachers. And you see, again, I'm okay. I forgot to mention you guys, over here. I'm doing the anastomosis again in the camera port shifted to 12 where I'm using a umbilical 10 and left, or sorry, right hypochondriac 5 port as my working ports. The reason is, again, it makes a better ergonomics. Second thing, it'll keep your anastomosis right under your vision, like how you do it in case of an open surgery. So these small shifts in camera port will save a lot of time for you, and it'll make a better anastomosis. So now that continuous one layer is done, I'm gonna just reinforce my suture line, which is totally not required, but as a school of thought, we've been taught to be do a three-layered anastomosis in case of laparoscopically, or four-layer anastomosis in case of open surgery. So I'm just gonna overrun my suture line using a 20 proline suture. There's nothing but seromuscular bites on either side of the gastric part and in the jejunum part. The reason to do reinforcing suture line is to make or put less tension on your underlying sutures. So this reinforcement sutures just relieves much tension on the underlying continuous 20 PDA sutures. For those who want to start laparoscopic suturing, it's better to again invest in a good or a personal needle holder for that matter of sake. And I always prefer using a straight needle holder than a curved one. So it's every surgeon's preference to use whichever the needle holder they're comfortable with. So if someone who wants to have a start doing advanced cases or start doing lab suturing, it's better time to invest some money, probably some 10,000 or 8,000 rupees in a good needle holder, or preferably their choice of a curved or a straight one. I prefer using a straighted needle holder because it's easy to handle the needle, so there's nothing fancy about it. I'm not gonna close the entire suture line. I'm just gonna take some 3 to 4 interrupted sutures just to release tension on the underlying 20 PDS. So the important thing again here by when taking your bite is to make sure you use the curvature of the needle instead of just like poking it and riding it. So you have to make sure that you use the curvature pretty well because there'll be less tissue damage over there. So the gastrojejunostomy in case of any peptic ulcer disease is nothing but a drainage procedure where it bypasses the side of obstruction. And again, the reason we do a truncal vagotomy is to reduce your acid secretion, and it will decrease the risk of recurrent peptic ulcer disease. When you have taken your the last layer, it's better to anchor the curvature of the jejunal loop on either side of the stomach to make sure there is no acute angling of the jejunum on either side or through the anastomosis. So see, now I'm taking stay sutures or bunch of seromuscular bites on either side of the anastomotic side because again it releases tension or it reduces the pulling of the anastomosis. So I'm basically aligning the uh, anastomosis once again. And I'm taking another bite on either side of the gastrojejuno anastomosis just to release tension on the gastrojejunostomy side. And so this completes our gastrojejuno anastomosis. Our next thing is to do a laparoscopic hand-sewn jejunal anastomosis. And now you see, now I'm going to take stay sutures using a 20 silk on either side of the jejunum. The site of selection is 15 centimeters distal to the gastrojejunostomy anastomosis. I'm going to do a Braun jejuno anastomosis. The reason I do a Braun jejuno anastomosis is to divert the bile flow and to prevent the biliary reflex into the gastrojejunostomy site. So I'm going to do a complete laparoscopic hand-sewn technique over here for my jejuno anastomosis. So the principle of complete laparoscopic hand-sewn bubble anastomosis remains the same as of open technique. Where in open technique, you're going to do in four-layer approach, and in laparoscopic, you're going to do a three-layered approach. So initially, we're going to take two anchoring bites on either side. Now, the length of anastomosis for any jejunostomy is ideally 5 centimeter. So we're going to make a 5 centimeter side to side jejunal anastomosis. And the suture materials I'm going to use over here is a 20 PDS and a 20 proline. So the 20 PDS, why? Because the needle size is better and it gives you better handling. So for an inside layer, which is our first and second layer, I'm going to use a 20 PDS, and outer, I'm going to use a 20 proline barb suture. So yeah, now I'm doing an enterotomy. You have to make sure the enterotomy doesn't override your edges of the anchoring bites. It should be maintained well within the edges of the anchoring bites. Once you make a good enterotomy, you have to start doing your bowel anastomosis. You have to be more careful while doing the enterotomy. Like, you shouldn't make a through and through cut. Have a good traction on either sides. Then make sure like you do it just on the anterior wall of the bowel. So for a 5 centimeter anastomosis, you have to do an enterotomy of maximum 4 centimeters. So this is the enterotomy getting done on the other side of the bowel. So now that enterotomy is done, we're going to start our bowel suturing. So for the bowel suturing, first is our first layer, which I'm going to make a conal stitch using a 20 PDS. For a left-handed person, the first bite, which is from serosata mucosa, is at 12 o'clock position. Then you're gonna come out at the your basically your 1 o'clock position, and again you're gonna enter at the 11 o'clock position, and you're gonna come out by 1 o'clock position. So this forms the conal stitch. So once the cornel stitch is done, we're gonna get the needle inside the lumen to make our first continuous layer of the ball anastomosis. And the principle again remains the same. Your assistant gonna follow the thread, and you're gonna keep taking the bites. So this I'm gonna take a through and through bite, but I'm gonna make sure that I've taken both the lumens, both the zeros of the both the sides, and I'm gonna uh, make the lie of the suture on the bowel. So this in our open technique will be the second layer, where the first layer will be the outer seromuscular layer. So it is important that before taking every bite, you're gonna make sure that you have taken serosa of both the sides of the lumen. So once you are reaching the corners, you should be more liberal on taking as many bites as you can, because the corners are tend to leak more. So you should make sure that you seal the corners adequately. Uh, I would suggest like you people to spend much time in securing the corners than in actually taking the other part of the bubble. So when doing a bubble anastomosis, you need a really good needle handling skills, which will only come after a lot of practice. So it's better to invest in a endo trainer and a good needle holder. So the reason we do a Braun jejunostomy is to prevent the bile reflex to the gastrojejunostomy site, which will lead to ulceration on the later life. So you see, before taking every through and through bite, I'm making sure that I'm taking both the serosas adequately, and the principle again remains the same. You're gonna take more serosa and less mucus. See, as you can see, I'm spending more time in securing the corners instead of jumping further to the anterior wall. So it's better to do as many as corner sutures to prevent to make a good seal. So now that I've secured the corner, I'm gonna take the needle out of the lumen to make a anterior layer of suturing. And this anterior layer suturing, like we have done in the previous gastrojejunostomy, it is just the more serosa and less mucosa. So you see, I'm taking a major chunk of serosa and minimal mucosa for the approximation of both layers. Now I'm making the second layer of your side to side jejunal anastomosis. So you see, it should be a controlled pull so that the sutures lie on a equal proportions. So after every suture, it is, or rather after every bite, it is important to keep the suture line under tension by placing the knots at every bite. So now that we're almost completing our second layer of the jejunal anastomosis, and again the camera position for our jejunal anastomosis is camera port at the 12 and on either sides as the two working ports, which is our right hypochondriac and the left lumbar port. So this completes our first and second layer of the jejunal anastomosis. Now the left thing is our reinforcing sutures on the third layer, which is nothing but a seromuscular layer. So yeah, over here I'm using a 20 barb suture, 20 barb protein suture. So we're almost completing our final layer of the jejunal anastomosis, and this completes the illustration of laparoscopic truncal vagotomy with Braun loop gastrojejunostomy. Thanks a lot for watching, guys. It would be great if you guys show some support by subscribing to the channel and sharing the content and making some comments, which motivates to make more such educational videos. So I'll see you guys next week with a different surgery.